the family medicine for the frontline physician to the European level. For us, it was a very hard work, from, let's say, 30 years ago. And it was very, very hard working. But in the present, we have some results. I want to present you our results as Association of Ultrasonography to the European level in the frontline physician. The frontline physician means the physician who are in the frontline, internal medicine, pediatrician, urgent emergency physician, but the most important thing is the family physician, the general practitioner, who are every day in the front line working with the patients. And let's say some things about the development of the clinical ultrasonography in the frontline physician, past and future perspectives of EUVEKUS and its leadership. And I want to present you some things, an introduction to the POCUS in primary care, the historical development and achievements, the current activities, the future perspectives, and the strategy of us, and conclusion and strategic importance. As an introduction, the primary care, as you know, the physicians face to the increasing diagnosis complexity and growing patients' expectation for safe, accurate diagnosis, to immediate clinical decisions, to reduce the referrals to the specialists or to the hospitals, and also the cost-effective care. And the POCUS address these challenges by provides non-invasive, real-time diagnosis capabilities at the point of care of the patients. The future direction include expectation, training, developing of the standardized curricula, and strengthening the accessibility of POCUS education. As a definition, the POCUS is a real-time image-based investigation performed directly by the clinician at the bedside, in the doctor's office, at home, or in the street. The purpose is directly correlated with the patient's symptoms to guide early diagnosis and treatment decisions. The clinical integration is very important, a powerful complement to the traditional examination, not a replacement. Both of these. The POCUS is always the clinical ultrasound, but the clinical ultrasound includes both POCUS directly correlated with the patient's symptoms and the comprehensive specialist ultrasounds by the Professor Christian Janssen. And why POCUS matters? The new stethoscope for the modern medicine will be the POCUS. We enhance the diagnosis, we could reduce the referrals, and we could improve the outcomes, and to demonstrate the better patient's outcomes in a finally. The POCUS make advanced diagnosis more accessible, and particularly in the primary and ambulatory settings where the specialized equipment was previously unavailable. We have some clinical challenge. This challenge highlights the evolving requirements for effective patient care. We have the growing diagnosis complexity now, rising the patient's expectations, need for the non-invasive capabilities, demand for real-time decisions-making tools, increasing the pressure for the cost-effective care, and also addressing health diagnosis. We have some historical development and some achievements, a decade of the innovation and leadership in the Europe also. We started in 2012 in funding of EUVEKUS in Vienna, and then from 2016 and 2024 we had 6 successful editions of Euroson POCUS Schools Vienna, bringing together frontline physicians from all the Europes, educators and speakers and international experts. It was very important for us. In 2016, we developed the Romanian POCUS curricula for the family medicine and co-author also in the EFSUMB and the WONCA Europe curriculas in the last time. And we have a memorandum of understanding with the European Federation of Ultrasonography in the 2022, and also we publicate in the 2024 and 2025 the European curricula of the point-of-care ultrasonography and the WONCA recommendation to use ultrasonography, then the point-of-care ultrasonography in the primary care in the frontline physician, and this is very important things. We starting to present workshops of the ultrasonography in the 2011 to the WFUMB Euroson Ultraschall in the Vienna. Then we continue also with the workshops of the point-of-care ultrasonography in frontline physician in the 2012, also in the WONCA Europe conference, World Conference, who held in Vienna. And then we go on, we contribute to an intelligent algorithmic software launched by us at the WONCA Copenhagen conference in 2016. And we remember about these workshops, and was a very important step for us in 2016. And also, we starting with the president of European Federation of Ultrasonography in that time, Professor Adrian Săftoiu, and we starting with the first Euroson POCUS School Vienna in the 2019. And was a wonderful time there, and we starting here in Vienna to University of Medicine with this EFSUMB endorsed course in the Vienna in 2019. Also, we starting some EUVEKUS cross-border projects, a project from 2 billion in between Romania and Serbia in the east part of Europe. And we starting with this, the ThyroScreen projects, with the more than 30 investigators, 20,000 patient questionnaires, and 6,400 patients examined by ultrasonography in that project. And we did a lot of things for the use of the ultrasonography in the thyroid practice to the patients. And this project had nominated the common approach to the improved early diagnosis and treatment of the thyroid cancer in the partner and area population between Romania and Serbia. And we give to the family practitioners more than 10 or 15 ultrasound machines then in Romania and also in Serbia. The EUVEKUS has launched some clinical studies of POCUS application in the family medicine, like European Service of the point-of-care ultrasonography application for the primary care and also the ambulatory care. Also, we launched the ultrasound oncological screening in high-risk patients in the primary health care with the intelligent diagnosis algorithm and the use of the artificial intelligence in the primary care. And also, we did the integrated thyroid ultrasound screening in the family medicine. The acronym was ThyroScreen. And we continue to launch a lot of projects. We have some advantages to the field through research and education. And we did the European POCUS survey, as I said, the oncological screening in the primary care and frontline physician, and the ThyroScreen projects. And also, we launched some educational projects together with our colleagues from different countries, a series of 8 online webinars of the 6 hours each with ultrasound application, and the project has the name Family Soon. And we working a lot of different kinds of books and atlases of the clinical ultrasonography from the primary care. And we have some educational impact in Romanian in the first time. The Romanian national milestones, we equip now, in this moment, 3,000 family practitioners with the ultrasound devices through the European projects. We launched the Train of Trainers program coordinated by the EUVEKUS through the EURACT Level 3 Leonardo dedicated program. We integrate POCUS training modules into the EURACT Leonardo Level 3 programs, as I said, and we had some, and we will have some ongoing projects like Euroson POCUS School, continues as a premier European educational platforms, and we starting a pilot TOT courses to expanding the structured training in the primary care and also in the frontline physician. We develop of multilingual online platforms and case library for primary and the frontline physicians. We have a series of 6 Euroson POCUS School conference held in Vienna, and we're starting the TOT POCUS in frontline physician projects, the training of trainers and doctors in the frontline physician of the point-of-care ultrasonography through the Leonardo Level 3 EURACT programs. We will continue to launch more educational workshops. And we remember another workshop in 2022 with the very important speakers from the European level. And we invite also our colleagues from Ukraine to support them as a bursary in the conference. And we are going on with another conference also in 2021, 2022, 2023. And we remember the bad times in the lockdown. And we was here in the lockdown with our colleagues from Europe to learn point-of-care ultrasonography, especially long point-of-care ultrasonography. Also, we continue with 2023, and we have very nice speakers, and we have a round table then, and we discuss about the curricula, and we're starting to working to the curricula then, together with Professor Shlomo Winker and together with Professor Christian Janssen, who was the president of European Federation of Ultrasonography. We did then, in 2022, the Memorandum of Understanding between EUVEKUS and European Federation of Ultrasonography, and we signed a document to support each other to continue and to make the curricula of point-of-care ultrasonography from the frontline physicians, and especially from the family medicine. And also, we contribute to the WONCA Europe position paper of the use of point-of-care ultrasonography, and we published together with our colleagues from the WONCA. And also, finally, we did a Delphi study in the Europe level to make the curricula and to be sure we validate our contribution to the curricula of point-of-care ultrasonography to the European level, together with our colleagues, Camilla Andersen, and our colleagues from the Task Force Group European Federation of Ultrasonography. We're starting an educational project of training of trainers in through the Leonardo Level 3 programs from the EURACT. And I had some important mentors from the European level, from the EURACT. And also we have some future perspective, like an educational expansion to establishment of a WONCA Europe Special Interest Group, SAIG, on clinical ultrasonography, European-wide scaling of trainers programs to the WONCA Europe level. We want to integrate of the POCUS curricula in the family medicine, in the frontline physician, and also in the residency training programs. We continue to research, and also we try to make some ethical and clinical standards. It's very important to be sure we are in the good direction, and we have the support of the European Federation of Ultrasonography in these things. We want to creating now a special interest group together with our colleagues from the other groups interested in the ultrasonography. And we formally request the approval of the WONCA Europe Executive Board for a new special interest group focused on clinical ultrasonography in the primary care. We promote structured education, we support the collaboration in research, we establish the quality standards, and the SAIG with the SERV, the Pan-European Platform for Innovation and policy advocacy in the clinical ultrasonography in the frontline physicians. And we continue with the clinical and strategic rationale, with the clinical necessity to academic contribution, to educational standardization, and WONCA strategic roles to the WONCA level. We have some future vision, a pan-European approach with the WONCA side group in the peak, with the educational expansion, with the research, with the innovation, with the policy and ethics approved in the WONCA. We established a WONCA European Special Interest Group, as I said, based to the education, based to the research, based to the policy, and based to the collaboration between WONCA Europe and European Federation of Ultrasonography, and we try to be like a bridge between these organizations. With strategic importance from the WONCA Europe, why WONCA Europe needs this side group, I think this strengthens the WONCA's position as a leader in the innovation diagnosis approach to address the technological gap between primary and specialist care, to support capacity building among family physicians across Europe, and to create a structured platform for international collaboration. And we have some expectation to outcomes, like enhance the diagnosis capabilities, to reduce the referrals to the secondary and the tertiary care, to improve patient satisfaction through the point of care diagnosis, and to generation of the robust evidence of the POCUS implementation. This is the first one. And our strategic vision for the future is strengthening the collaboration between European Federation and WONCA Europe, to make some accreditation programs, to research database, and we are actively pursuing to European funding projects. And the Euroson POCUS School Vienna 2025 is a pivot moment for the primary care ultrasonography, and with celebration a decades of work, we launched the official inauguration of the WONCA Europe side group, and we make the connection, first pan-European platform from the coordinated TOT programs in the point of ultrasonography through the WONCA Europe, through the European Federation and other organizations. We did the core curricula development, and we did the curricula, we launched the curricula, our EUVEKUS POCUS Care curriculum in 2023. We contribute together with our colleagues from the European Federation Task Force Group to the EFSUMB basic ultrasound curriculum for the primary care, and the WONCA European position, we contribute to the WONCA European position paper in 2024. As a conclusion, the next phase to the European-wide integration of point-of-view ultrasonography, training, research, and policy, ensuring the frontline physicians are empowered by modern diagnosis tools. Over the past decade, EUVEKUS leadership has transformed POCUS educational in European primary care, to develop the comprehensive training standards and curricula, and also to establish key international collaboration to create a sustainable educational model. The next step is the future vision to make the European-wide integration point-of-view ultrasonographic training, research, and policy, to ensuring frontline physicians are equipped with the essential diagnosis tools for modern clinical practice, and to integrate also the artificial intelligence in this. And join at the 6th edition of the Euroson POCUS School Vienna for the official launch of the WONCA Europe site on the clinical ultrasonography site group. Point-of-view ultrasonography represents not just a technological advance, but it's a fundamental shift in the how we approach diagnosis in the primary care. It's a revolution, as we said. We have some key recommendations to support the establishment of the WONCA Europe site group, to integrate the POCUS training in the family medicine residency program across the Europe, to advocate for equipment access in the under-resourced regions, and to participate into the Euroson POCUS School conferences. And ladies and gentlemen, we are welcome you, we are welcome our speakers, we are welcome our participants and our online participants, and declare this conference open. you are welcome. Welcome to EUVEKUS. Thank you. And now
because I'm here for the 6th time, that from year to year I'm losing my hair. When you see the photos one by one, you don't need to do ultrasound to see that, okay, from year to year we have much less hair. But again, it's a good pleasure to walk with you together step by step, Mihai. And and I think you mentioned most of the things that I wanted to say in my introduction, so I will be quite short and we will able to get back to our schedule. So my name is Professor Shlomo Winker. I'm from Israel, and I am the president of WONCA Europe already for more than 4 years, and I'm ending my term months from now, and I'm waiting every morning to finish it because it's a very demanding position. These are my affiliations. I am the Chief Medical Officer of one of the healthcare organizations in Israel. I'm a Vice Dean at the Tel Aviv University Medical School, and I am one of the co-chairs of the WONCA World Conference in Lisbon that will happen next month, less than 4 weeks from now. And even although I am planning to be there for about 2 weeks, it was quite important to me to join you, to make the effort to join you here today in Vienna. I will open my speech with a few words about WONCA. WONCA is the World Organization of Family Doctors, and I am the president of the European region. You will ask why Israel in the European region? Well, WONCA is split around the world according to the WHO regions, not related to continents, not related to EU. And for example, also in WONCA Europe, we have all the former Soviet Union Asian republics are still in WONCA Europe and not in Asian organization. This acronym is quite weird. It's the World Organization of National Colleges, Academics, and Academic Associations of General Practitioners and Family Physicians. This is the full name of our organization, but we simply call it WONCA, the World Organization of Family Doctors. Our mission is to improve the quality of life of people, to foster and maintain high standards of care in general practice and family medicine, to promote personal, comprehensive, and continuing care for the individual in the context of the family and the community, and to encourage and to support the development of academic organizations of general practitioners and family physicians, and this group fits exactly to our mission. WONCA Europe have 47 member countries. Unfortunately, not all European countries are members, and we are working hard to incorporate all the others. More than 100,000 family doctors, and also we have 14 networks and special interest groups, and if I will be here next year, I will have to change the number to 15 because we will add the special interest group on POCUS. It's a matter of approval by the Council, but I'm sure that it will be approved. Our goals are to achieve universal coverage through family medicine in all of Europe, to advocate integrated care to be implemented horizontally in primary care and vertically between levels of healthcare, to support the development of an undergraduate curriculum with focus on family medicine and specialty training in family medicine in all Europe. Just to let you know that nowadays the training is not uniform around Europe. In many other specialties, the specialty license is recognized all around the EU. It's not the same in family medicine, and we are working hard to change it. It's quite a challenge to change something in the European Parliament, but we are working, we started a long journey to make this change. Of course, we strengthen the research base of general practice family medicine. It is crucial, for example, for POCUS, because the case mix in primary care, the qualifications of the family doctor are totally different from other specialists in the field. And of course, we have to validate all the evidence in our own specialty and our own case mix of patients. To strengthen the development and quality of work and patient safety, and of course, to attract new and future general practitioners and family physicians. We are now in the POCUS revolution in primary care, and I think that everybody here in the audience will agree that the point-of-care ultrasound is actually the extension of our physical examination. It is the extension, and practically, and we have to be honest and to say, it is not a replacement of a comprehensive radiology or a specialist in radiology on ultrasound, and we don't aim to replace them in general. So what we achieved until now, I think that Mihai put all our achievements together in his lecture, so I will not go through it into details, but I would say that we had this curriculum for point-of-care ultrasound in primary care. We have the Memorandum of Understanding and also the WONCA Europe statement about point-of-care ultrasound, which I was also part of the team that pushed through to publish this statement as a publication. You have to know that in every council meeting, we are publishing a statement. But usually, the statement stays for the maximum in our council, the documentation on our website. But this time I insisted, that I know it is very important to publish it in a peer-reviewed journal that is in the PubMed, because later on everybody will cite it. So we made all the efforts, and at the end we published it. I will just go a little bit faster through my slides. So to optimize the POCUS revolution, we have to know the strengths and the clinical impact that we are doing it better, faster, and safer. And we know that, and I put attention to this in my previous presentation several years ago, that there are several key clinical areas where there is a good evidence for the use of point-of-care ultrasound in primary care. The scope of this meeting is much wider than those limited skills, but if you are beginners, you have to start your activity in those domains of cardiac, pulmonary, abdominal, vascular, and musculoskeletal skills. The coming two slides are very interesting. I asked AI, Gemini, how to introduce point-of-care ultrasound to a clinic. And what was the outcome? That the software, the AI said, okay, generate costume plan. Here I had to add which specific clinic I want, and it's free text, you know. In AI, you can write whatsoever. So I took two scenarios. One was an academic clinic, and they said, okay, the three phases are foundation, pilot program and training, and at the end, scale up and sustainability, which is, I presume it's something uniform to all projects. You don't have to be an AI to find that those are the steps. But as you can see, the program gave me different advices depending on the clinical scenario. And for example, and again, I will not go deep into the details, but for example, if it's an academic clinic in the pilot program, they said recruit 2 to 3 POCUS champions, which means at the beginning it will be very difficult to introduce this to everybody. But you have to find those that are very interested in the topic, and then implement a program, et cetera, and then the next stage of scaling and sustainability is to develop and to integrate the POCUS into the curriculum to residents and students, etc. And then if I will go to another scenario, for example, a rural solo clinical practice, then the focus is a little bit different. You have to find yourself POCUS applications that are relevant to your rural patients. You have to deal with fundraising because you have to buy the device. It's not an academic clinic. And then, of course, you have to enroll yourself to a training program because it's different. So as you can see, this very simple prompt that I wrote to the AI gave us very different scenarios of how to introduce point-of-care ultrasound in our daily working. So those are the steps in the roadmap. You have to choose a device today and tomorrow in our conference, in our meeting. You will see various kinds of devices of various levels of sophistication and of course of costs. And you have to choose the device that fits most to your expectations and to your the resources that you have to spend. And then, of course, you have to be trained. And most important is how to integrate point-of-care ultrasound to our daily working workflow. I know that for most of us, it will not be relevant to make point-of-care ultrasound to all our patients. You have to choose several patients every day, not all of them. And of course, at the end, the most important thing, and I know that Mihai did a great job in Romania, is the billing. At the end, our time is money, and if we are spending time in doing point-of-care ultrasound for our patients, it should be paid in our insurance and etc. So next thing, and I think that Mihai very much put the focus on this, is that in Lisbon, in a few weeks from now, we are expecting to create the new WONCA Europe special interest group about POCUS. I think it's a very important step, and we worked together very hard to bring ourselves to this moment. I'm the president, I'm running the executive board, but at the end, the council is the one that we should convince and should approve this special interest group, and I'm sure that it will be approved. So thank you all. I think I made it a little bit shorter that we will get back to the schedule. I hope that we will have a very successful and fruitful conference. And of course, again, thank you, Mihai, for the invitation. Thank you.
Thank you, Professor Shlomo Winker, who is one of our keynote speakers. And I want to special thanks to you, Shlomo, for your support and for your work in the implementation of point-of-care ultrasonography in the WONCA Europe and to the recommendation of position paper and position paper of the WONCA Europe in this kind of point-of-care ultrasonography. And we continue our presentation with a very important point-of-care topic in the frontline physician, not only in the primary care, in the frontline physician. And we want to speak about the eFast, but I have a little problem here. This block. Okay, thank you. And extending focus assessment with the sonography in the trauma and emergency for frontline physician and in the acute pathology in the emergency and in the primary care in the first level. What is POCUS and what is eFast? What is the difference between this? The POCUS is a target and a rapid exam at the place where the patient is. The patient is being consulting in the office, on the bed, in the home of the patients, in the accident and ambulance, on the street, and I was in an airport and I have an emergency and I use point-of-care ultrasonography to put the diagnosis in the airport in the Budapest. And this is the EFAST and also the POCUS. In acute, in emergency, life-threatening and chronic illness also. And for image, well seen in ultrasounds like fluids, like lithiasis, like tumors. It's performed by frontline physician who immediately interpret the ultrasound imaging in the clinical context to identify cause, to manage the case and care. The difference between the POCUS and EFAST is the EFAST you are doing in the trauma and an acute emergency only. And the point of care you did also in all the situation in the acute pathology and the subacute pathology. From the need for the rapid intervention to have an algorithm diagnosis and to have the management of the therapy of the patients. And who performs and who interprets? The point of care is doing by the attending clinician in each specialty for non-standardized sections. The EFAST, any qualified healthcare professional with the standardized sections like doctors, like paramedics and nurses, and also application in any organs or system. The clinical context could be with or without pain, jaundice, fever, anemia, and with the fast and accurate diagnosis of the lithiasis, the tumors, the fluids, the presence of the fluids of the air in the body. And to immediate the therapeutical decision, to have a very quick therapeutical decision, like cholecystectomy, surgical intervention, and so on. And I remember a very interesting, when I was in the Europa workshops in the conference, and we had some colleagues from Israel, and in the one hand had the probe, and in the other hand had the arm, the gun. And it was very interesting for us then, and we will see what has happened. And this is the time, and we must be prepared as a family physician, as a primary care. What does POCUS require? Dedicate ultrasound equipments like portable, miniaturized ultrasound probes, to use multimodal ultrasound like 2D, Doppler, elastography, and artificial intelligence in the softwares. We need to train medical staff. A few days, a few weeks, a few months, we will see and we will decide together. The curricula of POCUS in the frontline physician was did by the task force group of European Federation of Ultrasonography, and this was a very important step for us. We did that physical principle, we include the physical principle of ultrasounds, the notion about the equipment, the notion about the anatomy, the sonoanatomy, the notion of medical surgical emergencies, the ultrasonography indication, the clinical interpretation of information provided by ultrasound machine, and we need a lot of things to make this trainer of the trainees also. The POCUS could confirm or could exclude the aortic dissection, the major valvulopathy, the change in the cardiovascular dimension and kinetics, the visceral ruptures like liver, spleen, or kidney, the presence of the liquid, the fluids in the body, the air cavities, peritoneums, pericardium, collection, fluids in pleura and abdomen, an ectopic pregnancy to find the tumor, to find stones, to foreign bodies in the body. A brief history of the FAST and EFAST. The original FAST exam was the focused abdominal sonogram for trauma by Rotsky in 1996. Consists of 3 views, the right upper quadrant, the left upper quadrant, and the pelvic to rule out the bleeding in the abdomen for the trauma. And then the Kirkpatrick and published a paper in 2004 in the Journal of Trauma and established the EFAST exam, or extending focus assessment with sonography in trauma. The EFAST exam incorporates to evaluation of the lungs and heart, in addition to the abdomen pelvic problems. Now, the current EFAST exam consists of ultrasound scans evaluating for pathology in the abdomen, lungs, and heart. And we try to find the fluids present in the body, in the abdomen, in the cleave position of the peritoneum, in the different kinds of section and views, and we will see together who are these sections. Our objectives we will show you an easy and effective way to use point-of-care ultrasonography to perform the complete EFAST ultrasound examination in 5 steps, to evaluate a patient with suspect intra-abdominal or intrathoracic free fluid collection, to evaluate a patient with suspect cardiac tamponade, to evaluate a patient for a suspect pneumothorax or pneumoperitoneum, and detection of intraperitoneal, of intrathoracic or pericardial fluids in trauma. And we have some, in the face with the patient, some clinical question. Does the patient have blood? Does the patient have pericardial tamponade, have pneumothorax, or have pneumoperitoneum in emergency? And we could obtain some ultrasound and to respond to some ultrasound question. Is there fluid or air in the peritoneal cavity? Is there any fluid in the pericardial space? Are there signs of pericardial tamponade? Is there fluid or air in the pleural space? And of course, we can have some response to have a decision support for immediate laparoscopy, to refer the patient very, very fast to an emergency service, to choose the primary access site, the chest or abdomen, to release the pneumothorax and hemothorax, the transition to the secondary stage, and also, of course, to refer the patient to the computer tomography and other investigation, and to know the management of the case. The EFAST ultrasound exam indications are in the hemodynamical unstable trauma patients, in the abdominal and thoracic trauma of blunt or penetrating, to previously stable trauma patient with acute worsening in the clinical status, and to cardiovascular shock or unclear origin, to acute lower abdominal pain in young fertile women, if you have some suspicion, and acute emergency patients. But we have a lot of limitation. You must know this limitation. Does not localize the injuries, abdominal organs. The views may be limited in the patient with subcutaneous emphysema. Views may be limited to the patient who have a gastrointestinal tract injury with perforation with free air in the peritoneum. And also the 6 section must be complete under the time pressure without patient preparation. This is another kind. And you must know what probe to choose. And I remember you, the low frequency convex probe is for the high depth penetrations with the low resolution. You use this in abdomen, and you have the frequency between 2.55 megahertz, and you can use the high frequency probe, linear probe, with the short deep penetration for the bowels, for the breast, for the thyroid, and for the very superficial organs. And ultrasound preparation for EFAST, you cannot have time to make the preparation, but for the point of ultrasonography, you could make some preparation. And the patient is lying in the supine, lying down in the supine mode, and with the exam of in the Trendelenburg position, if you could, and the location of the ultrasound machine is place the ultrasound device all in the right side of the patient, and this makes it possible to scan with the right hand and manipulate the ultrasound controls with the left hand. And you use the type of transductions. In the EFAST, you can choose the phase array probe, the convex probe, and linear probe, and two presets to EFAST or abdominal exam. But you must know some very important things, and our speakers will show you today the movements of the probe to the patients, the cardinal transducer manipulation is very, very important, and it's very important to be very slow with this probe. And you can sliding with this probe. You can tilting this probe. You can rotate this probe, and you can rocking this probe, and we will show you today. And this is the type of the probes: linear, curvilinear, phased array, or all-in-one handheld. And my most important thing is to make a standardized exam. The standard ultrasound section are in plans, and you must know in the abdomen, you always, when you put the probe on the patient, the pointer and the indicator must be to the right side of the patient. And we have the longitudinal scans and the transversal scans. It's very important to know in every moment where are you in the body of the patient, in what standardized view, and also where is your patient on the monitor. Where is the head, where is the feet. And you must remember always, if you use a longitudinal plane, if you put the probe in the longitudinal, in the sagittal way, you must know always the head of the patient is in the right part of the monitor. Here is the monitor of the ultrasound machine. And if you make the longitudinal scans or view, you must know the head is to the right of the monitor, the feet are in the left of the monitor, and anterior and posterior is up and down of the monitor. If you use the transverse plane, you must know always when you put the probe, the right part of the body is in the right part of the monitor, and the left part of the body is in the left part of the monitor, anterior and posterior, always you must know. And you can find these patients. And as I said to my students, always when you put the patient, you must remember you cut the patient and you have the patient of the monitor with this direction. In the sagittal, the head is in the left, the feet are on the right, and also if you have the transversal, is this anterior, posterior, right and left of the patient on the monitor, on the desktop. And also you must have in your mind and to remember the pathology, the abdominal pelvic pathology in the different topographical anatomical region. In the right upper quadrant, you can have the cholecystitis, the gallbladder stones, the common bile ducts and disease, and the duodenal disease and ulcer, the hepatitis, the liver tumor, and so on. Different type of pathology in different kind of topographical region, and you must have this in your mind, what could be when a patient comes to you with a very strong pain in the epigastrium, in the right upper quadrant, and so on. And also, you put the probe on the patient, and when you put the probe on the patient, you must know where to find and what to find to the patient. And the EFAST evaluates several potential space in the peritoneal cavity for the pathologic fluid in the green, like this. And this is the body, and this is longitudinal section. This is the head of the patient. This is the feet of the patient, anterior and posterior. And you must examine always to see the Morrison space between the uterus and rectus in the woman. You must see the second, the A Morrison space between the liver and right kidney. You must see the caudal edge of the liver, and very important is the hepatodiaphragmatic space where you can find the fluids. Here are the fluids in the green color in the abdominal. And you can find the fluids in the heart, in the pericardium, or you can find the fluids in the recessus between the diaphragma and costal diaphragmatic recessus. And You can find some image, from some nice image like this, in the bowels, with the fluid into between the bowels, and the fluid into between the bowels in the cecum region. This is the cecum. This is the presence of the fluid with the anechoic image in the peritoneum. This is the bowel. This is the presence of the fluid into between bowels. This is the bowel into between the anechoic image of the fluids, because the fluids are always in the black coded. And the EFAST exam protocol, step by step. This EFAST exam answered 4 questions. Does my patient have fluid in the abdomen, free fluid in the chest, have pericardial fluid, have pneumothorax or pneumoperitoneum? And we'll first introduce you the 6 steps from how to perform EFAST ultrasound exam, and then in the next section we will give you exams of the measured EFAST pathology who could find. And the EFAST sequence are the right upper quadrant, the left upper quadrant, the pelvic view, the cardiac xiphoid view, or the parasternal long axis view, and the lungs in the right and the left in the anterior part in the between 2 and 3 intercostal space. And let's start with the free peritoneal fluid. It's a high sensitivity and specificity in detecting small amounts of the free fluids, ascites, blood, urine, and so on. But most important thing is to find the presence of the fluid in the body, and then we will see what to do with the patients. And you can observe here the Douglas space between the uterus and rectus, and presence of liquid here. This is the urinary bladder in the woman. Also, you can observe here the presence of the liquid above the diaphragm. This is the spleen, and this is the costodiaphragmatic space, or perisplenic space, or peri-liver space, and here is the costodiaphragmatic space. And the EFAST right upper quadrant view is the first step. And to view the right upper quadrant, you have in mind this question: does my patient have free fluid in the right abdomen of chest? And because the liver is most commonly affected organ in the blunt abdominal trauma, the right upper quadrant is usually the most important section of EFAST. The right upper quadrant proposition and hand placement is very important to be in the mid-axillary line at the 10 right intercostal space. Your patient is lying in supine mode. And when you have this section in the longitudinal, in the axillary, or right longitudinal scanning, you can observe here the right kidney, the psoas muscles, the liver, the gallbladder also, and the most important is into between the liver and the right kidney is this Morrison pouch, or Morrison space, and here you can find the fluid, the presence of fluid. This is the normal with the liver, with the kidney, and the Morrison space virtually, and the psoas muscle. And you can observe in this image the presence of the fluid into between the right kidney and the liver, the presence of anechoic image. This is the presence of the fluid into between liver and right kidney, and this is the Morrison space with the liquid in the fluid in the peritoneum. This is normal. You can make some morphometrical measurements of the kidney and to the liver. This is the diaphragm, and this is the longitudinal section in the axillary, in the flank right upper quadrant. This is the liver, the steatotic liver with the kidney. Normal, not presence of the fluid in the Morrison space. This is the same section, and this is the presence in the Morrison space and the lower edge of the liver, the presence of the liquid, the fluid. The presence of the fluid into between the liver and to between the right kidney And also you can find the presence of the liquid, of the fluid, in the recessus, costodiaphragmatic recessus, above the diaphragma. And you can find the both, the presence of the liquid below the diaphragma and above the diaphragma. You can observe here the presence of fluid in the costodiaphragmatic recessus and also in the peritoneus in the merism space. And present the liquid above the diaphragma in oblique section. This is the oblique section. And this is the linear axillary. And you can have the floating of the liver lobe into the fluid. And this is the Morrison space with the liquid. The presence of the liquid into the Morrison space above and below the diaphragma. And also you can make contrast to have a very nice image to know where is bleeding. And also the presence of the liquid in the pericholecystic gallbladder. You can find the presence of the fluid when you have bleeding in the peritoneum. The second step is the EFAST left upper quadrant view. And you can answer, does my patient have free fluid in the abdomen or left thorax in the both? And you can put the probe in the longitudinal in the posterior axillary line around the between 8 and 10 intercostal space, but a little bit oblique in the posterior with the knuckles to the base. And this very important sign, the spleen is fairly posterior. And you can observe here the spleen, the left kidney, and also it's very important to know the liquid. If you have the liquid in the peritoneum, you find the liquid perisplenic space, because into between the spleen and the left kidney is a ligament, the spleno-kidney ligament, who not approve the liquid to be into between the spleen and the left kidney, like in the right part of the section. And this is some image with the spleen. You must know, you can find the mirror image artifact when you put the probe in this position, and you can find like a hepatization of the lung. It's an artifact, it's not a real image. You must know this. And you must know, as I said, between the spleen and the diaphragm is not, cannot find, you can find the perisplenic space in the presence of the liquid or the fluid there. And this is the pathological image. This is the lung, this is the lung, this is the spleen, this is the left kidney, and you can find here the liquid and perisplenic space. And this is the normal spleen, left kidney, and into between the splenic and the kidney. Normal image, and presence of the liquid here, perisplenic, between the diaphragma and the spleen, into between the diaphragma and the spleen. Or above the diaphragma, you can find here the liquid in the thorax, in the left thorax. Or you can find the rupture of the spleen and the presence of the liquid, perisplenic, and into the spleen. Also, the presence of the liquid into between the spleen, the perisplenic space, and also to the lower ledge of the left kidney. Presence the liquid of the fluid in the pleural, in the costodiaphragmatic space, or you can find this. This is a very small image of the transonic image in the trauma of the spleen. This is the trauma of the spleen, a very small image in the first step. And we will continue to see this image. We make also the Zeus, the contrast. We put the elastography to see. You can observe the spleen with the heart stiffness. And we continue. We make the Zeus, the contrast. And this is the second step. You can observe, enlarge the hemorrhage of the hematoma of the spleen. And we put all together, and we find also the liquid perisplenic was a rupture of the spleen, the hematoma of the spleen in the 2 steps. And we continue. You can use also the multimodal ultrasonography. In the pelvic view, it's very important to use 2 sections, 2 views, longitudinal and transversal view. And you must remember, to the woman, you have the Morrison, the Douglas pouch into between the uterus and the rectum, and to the men's, you can find the Douglas pouch into between the urinary bladder and the rectum. And also here is the prostatis, here is the uterus to the woman. This is a difference. And you use also the transverse view, and you can find the rectum, uterus, and bladder, urinary bladder to the woman. And also to the men's, the prostate. And let's see. This is the urinary bladder, this is the uterus, this is the Douglas space with the presence of the fluids in the Douglas pouch. Also, you can find here another presence of the in the Douglas space of the presence of the fluid, or a large amount of the liquid, of the fluid in the Douglas pouch. Also, the presence of the liquid in the Douglas pouch, and this is the uterus, the urinary bladder, and this is the Douglas pouch in the longitudinal section. Douglas pouch with the liquid, urinary bladder, and uterus. We can measure, and you can approach the quantitative of the liquid, the quantity of the liquid, the amount of the liquid. And Douglas pouch, Douglas pouch, Douglas pouch with the liquid, Douglas pouch with the liquid. And the pneumoperitoneus is the second you can find in the abdominal ultrasonography in the EFAST. And if you have air in the peritoneum, you can find some enhanced peritoneal strip signs. This is the reverberation into the air, and this enhancement peritoneal stripe sign is very important. If you find this in the patient, you must know you could have there the pneumoperitoneum. And let's see some image, and you can observe here the reverberation. And we continue with the cardiac, with the step 4, the cardiac subxaphoid view. And the cardiac subxaphoid view, you put the probe into the epigastrium through the liver lobe, left liver lobe, to see the pericardium, to see the heart. And this is the cardiac subxaphoid view. And the point of the probe indicator towards the patient right, using the liver as a acoustic window, simultaneously press the probe into the patient's abdomen while tilting the probe to see better the pericardium. Also, you can use a second image. If you don't have very good image in the first one, you can use the cardiac parasternal long axis, and you ensure your third and fourth fingers in the second or third left intercostal space, just lateral of the sternum. And you can find this image with the left ventriculum, with the left atrium, with the aorta, in the right ventriculum. This is the image you can find. And you can compare these 2 images. This is a subxaphoid view or apical view with the 4 chambers you can observe here. This is the normal heart. This is the normal image. You can observe the similarity between the anatomical and the sonanatomy of the ultrasonography. And you can find here in the pericardium the presence of the fluid in the hemopericardium. And this is the ultrasound protocol for the focus, but we use just the parasternal long axis on the subxaphoid subcostal view. And how to put the probe there. In the subxaphoid view is the best window to view the pericardial effusion and hemopericarд and the atrial septum. The patient is lying down in the dorsal decubitus, and place the ultrasound probe transversally with the marker in the left of the patient in the epigastrium. And you can observe this nice image. This is the liver. You look through the liver, and you can observe here the pericardium and the left atrium, left ventriculum, right ventriculum, and pericardium. And we go on. You can observe this image with the presence of the fluid in the pericardium, with the anechoic image and the beats of the heart. Also presence in a small amount, and in the parastellar long axis view, you place the ultrasound probe into between third and fourth intercostal space, so that marker is orientated to the right shoulder on the patient of approximately to 11 o'clock. And I will show you in the hands-on session. You can observe the presence of the liquid into the pericardium. Presence of the liquid in the pericardium here. This is the heart, this is the pericardium. Pericardium, we put the Doppler, we use multimodal, we use M-mode to be sure it is presence of the fluid in the pericardium. In the step 5, I not insist too much because today you will see the EFAST of the lung view and the focus of the lung view. And the lung probe position in the hand placement, you must put to point your indicator toward the patient head, and you must have one intercostal space between 2 and 3rd space. And you must identify 2 things. To identify 2 ribs shadows or betting sign, and to identify lung sliding. It's like an ants marching on the line, and you will see. This is the true costal and shadowing of the costal. And this is the intercostal muscle, and this is the lung, the parenchyma of the lung, with the A lines, you will see. And this is the nice image with the pleural line. This is the pleural line. And you can see here the bat wings image with the shadow of 2 costal. And this is the presence of A lines. It's parallel with the pleural line. Or you can have the B lines who are perpendicular to the pleural line when you have the pneumonia or another edema, pulmonary edema. And this is the normal anastomosis anatomy. This is the soft tissue. This is the soft tissue. This is the intercostal muscles. This is the rib. This is the true ribs. And the true ribs make this rib shadow like bat wings. And also you have the A lines is parallel with the pleura, the pleural line. And you can observe the sliding of the pleura, sliding of the lung. You can see, you can observe here, like this is the pleural line, sliding. It's normal to sliding. And this is the intercostal muscles, this is the bat wing sign, and this is the A lines. But you can have this image with the absence of the lung sliding. You can see here the sliding of the lung. You can see the without lung sliding. Also, an image with the lung sliding and A lines. This is the intercostal muscle. We use here the linear probe to have nice image. And if you put here, you don't have any sliding of the lung. And this is the pneumothorax. And when you have the pneumothorax, you identify, you can use also to put the diagnosis, the M-mode ultrasonography. When you put the M-mode, you see just these 3 aspects. This is the seashore sign. The sky is the subcutaneous tissue, or the tegument, and the skin. Also, you can have here the ocean is the muscle, the intercostal muscle, and the beach is the pleural line. And this is normal when you have the M-mode use. I will show you in the hands-on. But if you have the second is the absence of the lung sliding, and you have the barcode sign in M mode. This is like a barcode when you have the pneumothorax. This you can observe. This is not normal lung sliding. If you have the suspicion of the pneumothorax, the first one is the absence of the lung sliding. And the second, if lung sliding is absent, you should not automatically assume the pneumothorax. If the lung point is present, you can rule pneumothorax with 100% if you have the lung point. What does it mean, the lung point? The lung point is when you can see the transition between the normal lung and also in the absence of the, okay, thank you. Absence of the lung sliding, this is the transition point between the collapsed lung and the normal lung. You can observe here the absence of the lung sliding when you have the pneumothorax, because the lung are collapsed, and into between the normal sliding and the absence of sliding, you can observe here a little point. This is the long point between the normal parenchyma of the lung and the collapsed parenchyma of the lung. And you can observe the B lines who are perpendicular when you have the edema in the parenchyma. Also, you can observe the presence of the fluid in the pleura and the presence of the liquid in the costodiaphragmatic recessus. And also you can have here the spine sign. You can observe the spine when you have the liquid in the pleura. The presence of the liquid in the pleura, the presence of the liquid in the pleura, the presence of the liquid in the pleura, presence of the liquid in the pleura. And this is the presence of the liquid in the pleural space. And finally, you can make the EFA scan algorithm for the hemopericardial, for the hemothorax, for the hemoperitoneum, in the different kind, and you must to know what to do with your patient when you have this algorithm. And taking home messages, the use of the point of care EFAS is not limited to a specialty, protocol, or organ system. POCUS provides real-time diagnosis and monitoring of the information to attending clinicians. A negative EFAS does not exclude always the presence of intra-abdominal, intrathoracic lesion. It can be used to enhance the safety of the standard ultrasound guide procedures and to introduction of the POCUS curriculum and training at the medical school at the greater level in the is mandatory, like in Israel. Advanced portable systems are required. It can provide reliable diagnosis at low cost, and POCUS will become a standard tool of the frontline clinician like now in the gynecology specialist or cardiology specialist. And thank you for this presentation. And I have a question for you. The final question of the presentation: what will be our future, man or machine or both? You will answer to me, and I am at your displeasure with for your question. Please, if you have any question. Yes.
I'll do my best to make it as easy as is possible for you. I know that some of you are beginners. I hope I'm going to be clear for those that are beginners, and I really hope I'm not going to bore you for those of you that you are already advanced. But I think what is important in ultrasound is mostly to know the normal, to know how the normal appearance is, to scan the entire organ, and then if you know anatomy, you are not going to have a problem. Because even if you are not going to know what kind of pathology you are facing, you are knowing that it's something abnormal. And this means that you can either ask another colleague to see the patient, or you can order other investigation to find out which is the problem. This is what is important, and this is why ultrasound is a very good POCUS tool, very good clinical tool, because you can talk with your patient, and afterwards you can put the probe on the abdomen or on the lung or on the thyroid and find out if there is a problem or not. But let's go back to the liver. We always start in ultrasound from anatomy. Otherwise, you are not going to understand what you are looking at. Remember that when you place the probe on the abdomen of your patient, you make like a slice with ultrasound beams through the patient. It's somehow similar to CT and MRI, but here we use our probe and we can make as many slices as we want. And you look to the image from the legs of the patient. This is how the ultrasound image is formed. And this is why I put you here the anatomical view of the liver, how it looks anatomically if you cut the abdomen of a patient and you look on the surface with the left liver lobe and the right liver lobe. But I put also the inferior aspect, because if your patient is lying like this and you make the slice, it's actually this way how you are going to see the liver. And I want you to remember the position of the gallbladder, the position of the portal vein, the inferior vena cava, which is always the vessel that is behind the liver, the ligamentum venosum, which you are going to find out it's a very important landmark when we measure segment 1, the caudate lobe. This is left liver lobe, this is right liver lobe, and this is ligamentum falciform. So if you remember this image, you are going to see that it looks similar in ultrasound. The only difference is that it's in black and white. Otherwise, it's what you are going to see. We take into consideration when we evaluate the liver, the structure of the liver, the vascular structures that are inside the liver, the bile ducts, which are also inside the liver, some of them, some outside, which are also important, and of course the relationship with the other organs that are surrounding the liver. The patient should be on fasting. It's the best way. You can evaluate the patient even if he is after a meal, but the image is not going to be the same, and you have to take into consideration this, especially for the gallbladder, for example. It's very important to completely and systematically sweep the entire structure of the liver. The liver is a large organ, so don't see only a small piece of the liver, because in the other half of the liver you can have a tumor. So you have to sweep the entire structure in several sections, and I'm going to show you how. You look for the vascular structures because we use them as landmarks, but we also look for the pathology. And you have to have a very homogeneous liver. This is how it's normal. It looks like salt and pepper, but very smooth. It's a very smooth structure. And ultrasound liver, it's also creating an ultrasound window to evaluate other organs, like the gallbladder, for example, or the right kidney. So it's very helpful. Usually, when you want to see the liver, firstly, you place the transducer subcostally in a right oblique fashion. You put the transducer like this, and you sweep with the transducer the entire organ. The liver usually stays beneath the ribs. This means that you need to ask your patient to breathe in and hold. In order for the diaphragm to come down, the liver is going to come down and is going to be more accessible to your evaluation. This is how you put the probe. This is the anatomical view, and this is what you are going to see in ultrasound. So you are going to see the organ that is like salt and pepper. Remember that I told you there are structures that are in relationship with the liver. You see here the right kidney, which is behind the liver in this area. And you saw also the diaphragm. The movie will start again, and I'm showing you again. So I have left liver lobe and right liver lobe. This is the diaphragma, this is the kidney. And in the middle of the liver, here, you have the portal vein. The vessel that is behind the liver is inferior vena cava. Kidney, inferior vena cava. So I make the slides like this, so I see in the back, there is the diaphragma. This is why the image looks like this. Here, it's anterior. Here, it's posterior. This is the right side of my patient, and this is the left side of my patient. I know for sure also from the image that this is correct, because here is the heart on the left side of my patient, and the liver is on the right side of my patient. If you do not understand something, please feel free to ask me anything you want, and while we are going to have the hands-on training again, you can ask any questions. They are all the questions are welcomed. You cannot see the whole liver in one sweeping because it's large. So you are going to need to place the transducer first for the left liver lobe. The left liver lobe is more in the epigastrum, so you are placing the transducer like this. Remember that you see from the legs of the patient. So this is left liver lobe. The angle of the left liver lobe shows you the left side of the patient, left liver lobe. Inferior vena cava, the vessel behind the liver. This is the gallbladder inside the liver. And I swept the entire left liver lobe by one movement from up to down. Now I'm up, I see the heart. I know I'm up. I go down, down, down through the liver. We are going to see other organs. Here is the pancreas. It's going to be another presentation. But this is how I sweep to see the entire structure of the left liver lobe. Then I move the transducer, so I place the transducer like this. Then I move the transducer on the right side, and I'm going to see the right liver lobe. And here, behind, you see very nicely the diaphragma, and if you remember from the images of Mihai, this is abdomen where the liver is, and here, behind you are in the upper part, so this is actually the pleural space. So if you are going to find something black here, it's going to be liquid in the pleura. If you are going to find something black here, the liquid is beneath the diaphragma, so it's ascites. It's extremely easy. Ultrasound is the best method to look for free fluid in the abdomen, for fluid in the pleura, also for gas in the abdomen. Even if all know that we use X-ray, but ultrasound is also very good. While you are sweeping also the right liver lobe, you see some structures inside. So I'm going to stop the movie and show you. So this is the diaphragma. You saw the hepatic veins. We are going to come back to this. Now you see in the middle of the liver the bifurcation of the portal vein with the right branch and the left branch. And you see the gallbladder. If you remember the first image that I have showed you with the anatomy, it looked like this. And here it's ligamentum venosum. This is the inferior vena cava. This is the caudate lobe. And here is ligamentum falciforum. It's only anatomy, and it's not complicated. I know at the beginning looks very complicated, but it's not. So when we are sweeping through the liver, I told you that we look for different structures. First, the hepatic veins, but we are talking about vessels now. There are three, the right, the middle, and the left branch. They are going together in the inferior vena cava, and they look like the goose leg. There is a lot of variability in how they are looking at, how they look like, but it's important to see them, because if you don't see them, maybe it's Budd-Chiari syndrome. To see them black, because there is liquid inside, so they are going to look black, and to see that they are not dilated and they go in the inferior vena cava. Next, you go down. Now you see the hepatic veins. Now you go down in the middle of the liver, and we are going to see the bifurcation of the portal vein. Again, that's the heart, inferior vena cava. And now you see the bifurcation of the portal vein with the left branch and the right branch. So remember that the vessel that is behind the liver is always inferior vena cava. The vessel that is in the middle of the liver is the portal vein. And you can assess them by moving the transducer. Don't move fast. Just take your time and sweep the structure very nicely in order to see correctly what it is inside. It's not enough to see the structure in one section. Always in ultrasound, you have to see the structure in two sections. So from transverse section, what we have described until now, we move in longitudinal sections by moving the transducer 90 degrees clockwise. This is conventional. It was established at the beginning that this is how we move the transducer. If we move it the other way around, you are going to see the mirror image. Usually the pictures in the books are by placing the transducer 90 degrees clockwise. This means that you are going to have here the head of the patient and here the legs of the patient, anterior and posterior. This is how you place the transducer, and for sweeping the entire lever, either you start on the right side and you go to the middle, or you start in the middle and go to the right side. In this image, I started in the flank, so I saw first the kidney. So through the liver, I use the acoustic window of the liver, and I see the kidney, and behind the kidney, you see the psoas muscle. I'm going now further, more to the middle. I see the inferior vena cava going behind, and I see some other structures. So inferior vena cava behind the liver, vessel going inside the liver is the portal vein. This is the hilum, and we are going to come back to this. And you are going to see also the gallbladder while you are sweeping this. Here is the gallbladder, and we go further to the middle, and here we are already in the left liver lobe, and I have finished the sweeping with the transducer of the liver in the longitudinal section. Hilum. We have a special section for the hilum. This is perpendicular on the costal rim, and if you make a virtual line between the umbilicus and the shoulder of the patient, you don't have to remember this, but I just try to explain you, and you place the transducer where this line is crossing the ribs, you are going to find the hilum. Remember that you need the longitudinal section for this, either with the patient in supine position or with the patient on the left side, and the landmark that we are using is the portal vein, because it's larger than the main biliary duct. The vessel that is going behind the liver is inferior vena cava. The vessel that goes inside the liver is the portal vein. Here you have the hepatic artery, and the small line in front is the main biliary duct. That's the main biliary duct. The hepatic artery and the main biliary duct and the portal vein do not go in the same section. This is why usually the hepatic artery is a circle, and the vein and the main biliary duct are lines. So you see them very nicely. And you can follow. It's easier to find the main biliary duct here and follow it to the head of the pancreas. And by changing the little bit of the position of the transducer, you are going to see also the gallbladder. So portal vein, main biliary duct, perpendicular on the ribs in this fashion. We always have to look also on the upper part of the liver. Even if you can sweep the entire liver with the section that I have showed you, it's always advisable to put the probe also intercostally and to look at the upper part of the liver. This is the diaphragma. This is the gas from the lung. You see that I don't see anything. It's going to be another presentation about the thorax. And this is the liver, and this is the upper part of the liver. This is how you place the transducer, and it's also the area where usually we do the liver biopsies. If you want to assess the surface of the liver, which is very important for the gastroenterologist, because an irregular surface of the liver means that the patient has liver cirrhosis, it's advisable to use a higher frequency probe. We evaluate the abdomen usually with 2.5 to 5 megahertz, the convex probe. All the images that I've showed you at the beginning were with the convex probe. In order to see more detailed, but you lose penetration, you go to higher frequency from 5, 7.5, 10 megahertz. With this, you do not have penetration. You are not going to see the aorta and inferior vena cava because they are far away. But you are going to see very nicely the surface of the liver, like in this image. You see the liver, the structure, and you see the surface that it's normal, it's very sharp, and the patient doesn't have liver cirrhosis. So remember that you can use also this trick. When we talk about the structure of the liver, we want to know if it's homogeneous or inhomogeneous, if there are focal lesions. The focal lesions can be transonic, so black with a posterior amplification like a cyst, or they can be hypoechoic or hyperechoic. Hyperechoic means whiter. Sometimes if there are calcification, you are going to have also a posterior shadow, just to know what we are the terms that we are going to use. Regarding the liver, the next part is usually what it's very stressful for the doctors, is the segmentation. You cannot say precisely where the lesion is in ultrasound as a segment. You need sectional imaging always, CT or MRI. So nobody's going to operate a patient only on ultrasound for a liver tumor. But you have to talk the same language. So you have to write in your report where the tumor is for another doctor, if looks to the patient, to look where the tumor should be. For left liver lobe, it's easy because it's small. The right liver lobe, it's a little bit more difficult because if you say it's in the left liver lobe, everybody's going to find it. If you say in the liver, nobody's going to know where the tumor is. And if you say it's in the right liver lobe, it's always good to say something more where in the right liver lobe. Remember that you can use the landmarks, the vessels, the gallbladder to say it's near the gallbladder, it's near the hepatic vein, but if you can tell the other doctor where the segment, which segment is involved, it's also a good thing. We have segments 2 and 3 here. We have segment 4, 5, 6, 7, 8. And remember this is not the view that we have in ultrasound. This is the view that we have in ultrasound. So it's very easy to remember them because it's like a shell. You start with segment 1, which is between the inferior vena cava and ligamentum venosum, and you go counterclockwise, and you have segment 2, segment 3, which is left liver lobe. Then you are going to have ligamentum falciforum, and you have the gallbladder that are delineating segment 4. And on the other side of the gallbladder is segment 5, 7, and 6, and 7. Segment 8 is the dome. It's the upper part and posterior for the liver. So it's there, behind. So usually you see it intercostally, like I have showed you in previous images. Let's see how it looks like. Longitudinal view. This is the view where we are going to measure the caudate lobe. It's the only thing that we are measuring in the liver because a male that is tall is going to have a large liver. A slim, very short lady is going to have a small liver. So don't measure the liver because it's useless. It depends on how the patient is looking like. This is segment 1 between ligamentum venosum and inferior vena cava. We measure it anterior-posteriorly. In the hepatic vein, the left hepatic vein delineates segment 2 and segment 3. This is the transverse section, like a shell, like I've showed you, segment 1, 2, 3, ligamentum falciforum, and here the gallbladder. This is segment 4. And we go on the right side, and in longitudinal 5, it's anteriorly, 6, it's inferiorly, 7 and 8 are posteriorly and beneath the diaphragma. It's much easier in this view. Here you are going to see the gallbladder, and on the other side of the gallbladder in segment 4, which is here, you have segment 5, then it's 6, 7, and the upper part is segment 8. I don't want to stress you with this because I think it's more important to see that it's homogeneous, the liver, and to see there is a tumor inside. And if you are not going to know which segment it is, it's not going to be such a big problem. Because you can say that it's in the left liver lobe or it's in the right liver lobe, near the diaphragma or near the gallbladder or near the hepatic vein, for example. But remember this orientation that is very easy, like a shell, starting with segment 1, 2, 3, 4, 5, 6, 7. Remember here ligamentum falciforum, here the gallbladder, ligamentum venosum, and inferior vena cava. This was the liver. And now you are going to say, oh, another 20 minutes about the spleen. No, the spleen is actually quite easy to evaluate. The only problem that it is an intraperitoneal organ, but it's beneath the ribs. This means that usually you need the cooperation of the patient to breathe in and hold, for the spleen to come down, to assess it much easier. not always it's working. Whenever you have a small slim patient, remember to look for the spleen in supine position first. But if you do not see it, you move the patient on the right side and you use this approach. You put the probe between the ribs, like you put your hands in the pocket, and you are going to see the spleen. Usually the spleen has to be less than 12 centimeters in size. We measure it mostly longitudinally. You have to have the both splenic poles in the examination plane, and you have to see the hilum where you are going to make the measurement. And remember, again, that it's an organ where the size depends on the size of the patient. If you have a very tall patient that plays basketball, he's going to have a larger spleen as compared to a slim and short lady, for example. So in taller patients, we consider normal. Usually, we consider the normal spleen up to 12 centimeters. Whenever the spleen is between 12 and 13, we consider that it's an upper limit, and you need to make investigation. Maybe the patient has a problem. If it's more than 13, then it's splenomegaly. So you have a gray zone between 12 and 13 where you need to address the patient a little bit more. Otherwise, you just ask the patient to breathe in. This is the lung that is coming on the spleen. The patient breathes in, and you see the entire spleen. I'm going to show you images how you make the examination, again, either in supine or in right lateral decubitus. We use the spleen as acoustic window to see the kidney that is behind the spleen. Sometimes the deep inspiration and block the inspiration, it helps to see the spleen. Sometimes it doesn't help. So you need the cooperation of the patient. And again, you need to sweep the entire structure. But usually we use only the section where we see the entire spleen longitudinally, because there by sweeping, you see the entire structure. What you can have also normally in this patient, you can see an accessory spleen, which is found in up to 10% of the patients. It's a small spleen that is coming together with a large spleen. It's the same echogenicity, identical with the spleen, and it's usually between 1 and 2.5 centimeters, and it's usually near the spleen. We have to know them because it's not a lymph node, and you have to describe it. It's an anatomical version, and it's not abnormal. You see very nicely, here is the diaphragma, that was the lung. Through the spleen, you saw the kidney. This is the spleen, and there you have also the accessory spleen in this image. Left flank section. So, please always sweep systematically the entire organ, either liver or the spleen, at least in 2 sections for the liver. Identify the vascular structures because they are landmarks. Identify for the liver because it's important. You need to see the portal vein, the main biliary duct, the hepatic artery. Assess the echogenicity of the structure. It has to be homogeneous, both for the liver and for the spleen. Pay attention when you evaluate the spleen that you need to have both splenic poles in the same examination plane, but mostly, please examine. This is very, very important. And remember that you have a superpower. You see with sound inside your patient, which is actually extremely good. And if you can do it 5 minutes after you have talked to the patient, it's always a good thing. You always get information. Even no information, it's an information. Even if you don't see anything pathological, it's still an information. And you have here the WFUMB ultrasound book. It's free to download, and it has, you have all the ultrasound examination and everything inside. So please use it. It's a very good tool in clinical practice. Thank you.
Thank you very much.
congratulate the organizers, because the project is very good. Ultrasonography is becoming more and more important in our clinical practice, and especially for general practitioners, it's an essential procedure, in my opinion, and not only mine. Ultrasonography, it's a sort of sonovisualization. So because we have the clinical skills, we continue with the sonoauscultation and then sonovisualization. And because of that, we have these new machines, including the portable, and you now, because you are so many young people in the hall, you will have the possibility to take from your pocket the portable machine to put it on the region of where there is pain or something, some symptoms, and you are going to find the final diagnosis. So from this point of view, POCUS means to put the transducer on the suspected disease. As clinician, as doctor, as practitioner, this is POCUS. Point of care ultrasonography. So we try to optimize our clinical skills. That's why, because I'm gastroenterologist especially, I changed a little bit the order of my presentation. I start with liver, because liver is the largest organ in the abdomen and very important also, and spleen, of course, at the same level. And then I wish to present you, first of all, I would like to congratulate and to address many thanks to Professor Alina Popescu for the very nice presentation, which for me is very important, because for me it's very important and very difficult to explain the normal. You know, I am not an anatomist. I know a lot of ultrasound. I did ultrasound for many, many years, 10 of years. I examined, I believe, in my opinion, at least 100,000 patients in my life, clinical life, but even now I don't know exactly what means this point or this point. For me, the clinical diagnosis and the final diagnosis is the most important. However, I would like again to underline that ultrasonography is not a visualization, but is understanding what is happening from different point of view, and we have multiple parametric or multimodal way of understanding ultrasonography, because vibrations in many kinds are giving different information. The most important information is grayscale. The most important is morphology. But after that, we have Doppler, which was discovered by an Austrian many years ago here in this town, Doppler. And now we have the possibility, because of this Doppler, to see what is happening into the vessels, how the blood is circulating, what is direction, what is the speed, and so on, non-invasively. Then some people invented also elastography, very clever people, very clever people. And because of elastography, now we have the possibility to see what is the fibrosis into the liver. In a way, it's not exactly the fibrosis, it's the rigidity, but in general, it's a very important criteria. Then we have another mode, which is Doppler spectral, which is quantitative, and we have also contrast. Contrast is very interesting because it's another mode of sonography. It's harmonic mode. It's giving informations about what is happened in microcirculation. So when you understand very well the actual status of ultrasonography from the technological point of view, you are going to see morphology, you are going to see speed of vessels, you can calculate debits, speeds, and so on, and also to understand physiological and physiopathological events, what is happening in some situations. So this is about introduction. Well, what is the use in general of ultrasonography for liver? Many years ago, it was to detect tumors and to appreciate if the tumors are solid or liquid. Now we have a lot of applications, starting what is happening into the general practitioner, because you have many situations when you see the patient has something, because that's why he's coming to you, of course. But also ultrasonography is good not only for general practitioners, but for specialists like gastroenterologists, for surgical doctors, and so on. For instance, we might use this procedure to make the diagnosis at a certain level. Is not a perfect one, but a very good one to alert you that there is something happening. Diffuse liver disease, fatty liver, including hepatitis, acute hepatitis, we might make the diagnosis of acute hepatitis in some circumstances. Cirrhosis is a very, very clear diagnosis we can make. Tumors to detect, to appreciate the stage, to decide if the tumor is malignant, probably, not certainly, probably, malignant or benign, to evaluate the disease under the treatment, to detect recurrences of neoplasm, trauma, guided invisits, and so on. And now let's go to the pathology. This is the first application that we use, unfortunately, for many people, because at least in Romania we have a lot of fat people. They are eating heavily and not good food, and that's why they are obese, many of them, and they have also fatty liver. The fatty liver can be diagnosed from one blick, from one image, because when you put a transducer into the intercostal space, you are going to find enlarged liver in many situations, and then you are going to find this difference between upper part of the liver under the capsule, which is bright, which is white, and this part, which is nearby the diaphragm, which is black. And this difference is because there is attenuation into the liver, and this is very typical for two situations, for steatosis and for fibrosis. In this case, it's not fibrosis. Why is not fibrosis? Because the liver, the structure of the liver is not unhomogeneous, it's homogeneous, is very nice, is very smooth, as you can see here, and also because I have the way to quantify, because ultrasonography now is giving by elastography to say if there is rigid parenchyma or a normal. So first step is to detect the very clear image. This is a steatosis, but also I exclude the fibrosis, and then I quantify the steatosis, because there are machines that are doing this, and they are saying in decibel on meters how is the attenuation, the UGAP. And from this point of view, we have the whole diagnosis in our hands, and we are going to send the patient to make some blood tests and then to give him the appropriate treatment. So fatty liver is the first application, which is very common. In acute hepatitis, you are going to find, of course, the patient has some symptoms. He's asthenic. He has maybe high level of liver enzymes. But from ultrasound, first, ultrasound in grayscale, we exclude advanced liver disease. We exclude the cirrhosis. Then we move to the hilum and we find lymph nodes, which are ovoid and echogenic, and these lymph nodes are very typical for inflammation. And then we move to the gallbladder. We are going to find this thickened wall, which is very typical for inflammation, which happens at the same time with hepatitis. There is also a sort of cholecystitis. And we have a suspicion, not a certitude, of acute disease of the liver, especially hepatitis. Cirrhosis is very easily to be diagnosed by ultrasonography, because we are going to have many modifications, morphological modifications of the liver. The liver could be enlarged or shrinked. The liver could be very unhomogeneous, because inside of the liver of cirrhosis there are nodules, regenerative nodules. The capsule of the liver is irregular, and then we are going to find dilated portal vein, and also splenomegalia, which means that if we measure the two poles of the spleen, we are going to have more than 12 centimeters, even much more because of that. So cirrhosis is very easily to be diagnosed. What are we going to look for in a patient with cirrhosis? First, we have the suspicion of cirrhosis. I said liver and spleen and the portal vein diameter, but then we move to the structure of the liver, which is given by this very excellent procedure, which is ultrasonography. And we are going to find nodules. The nodules could be, for instance, dysplastic. And in general situation, we have a special risk for hepatocarcinoma. The dysplastic nodules are black, are in general between 10 and 15, maybe 20 millimeters, and are many. So this kind of structure of the liver is very suspected to be a dysplastic nodule into a liver cirrhosis. But these nodules could be regenerative. This regeneration is not so dangerous for the patient. But the nodules could be like this one, for instance, hyperechogenic. So these nodules are white, and they are not so dangerous for the patient. They are probably nodules of fibrosis, like this one or like this one. Some of them are black, and these black nodules are dangerous to become a hepatocellular carcinoma. So after measuring the liver, we see the structure of the liver. And when the structure of the liver is not homogeneous, but is nodular, we have to decide what kind of disease is. Is it a diffuse disease like cirrhosis, or maybe something more? After making the diagnosis of liver cirrhosis, and we have also the elastography to complete this diagnosis, we move to the complications of the cirrhosis. For instance, we look for water, for ascites, and this is this black area into the abdominal part, lesser part of the peritoneum. We move to the collaterals, which are very typical for liver cirrhosis. We use this way of putting the transducer on the abdominal wall on this line, and we are looking for the ligamentum teres, which is becoming dilated. This is a way of the liver to protect himself against the blood accident. You know that. We move to the round ligament, and we look for this image, which is very typical for recanalization of ligamentum teres, and sometimes we see by grayscale some thrombus into the portal vein, which also are complications in this kind of disease, which is cirrhosis. And of course, in some situation, after some shunts done by gastroenterologists who are doing invasive procedures, we might evaluate if a special procedure like TIPS, a portosystemic transjugular TIPS, is effective or not. Because if it is, we see the TIPS, this one, but the circulation of the blood is seen by the other mode. This is the Doppler mode, which is very important for this patient. I discussed about portal vein thrombosis. This is another application for that. In portal vein thrombosis, we are looking in grayscale to evaluate the portal vein and to measure the portal vein. In this situation, this is a dilated portal vein. Inside, there are echoes. This is echo-free. This is the blood we suspect. But we have the certitude when we put the Doppler. You can see the window here, the Doppler. This is the blood flow coming into the liver, and this is the thrombus. This thrombus has benign characters because it's an echogenic thrombus. It's a large thrombus, and this is a situation that happens in many instances in advanced liver cirrhosis. What is next from this point of view? We have to be very careful because these patients, they have a great chance to develop hepatocellular carcinoma. So we have to examine these patients with liver cirrhosis every 4 to 6 months on a year. And to be very careful, to use a good technique, using different windows to examine the patient, and then to find for nodules more than 2 centimeters. These nodules are highly suspected to be hepatocellular carcinoma. For instance, here you make a comparison between the liver parenchyma, which is unhomogeneous, typically for cirrhosis, but this nodule is especially to be focused by some procedures. So when we detect this kind of nodule, we have the first step, suspicion of hepatocellular carcinoma. What do we do in order to clarify? Instead of liver biopsy, we try to avoid liver biopsy. We put the Doppler. We know that in Doppler we find small speed vessels. So when we find vessels in such a nodule, we have the second step of suspicion when there are, let's say, in a very dispersed pattern of the vessels into this kind of nodule, we have the suspicion of a neoplastic nodule. So first we detect by grayscale, and then we have a suspicion, a stronger suspicion by Doppler. We have many ways of evaluating vascularity. One of them is power Doppler, the other one is Doppler color, and also we have a pulse Doppler. When I put this acoustic window into the middle of the nodule, I find arterial vessels. This is another suspicion for hepatocellular carcinoma. So you can see that I judge in steps. First I detect, then I suspect, then I consolidate my suspicion by Doppler, and then I put the very specific examination for this kind of lesions. This is the contrast-enhanced ultrasonography. I inject into the vein microbubbles. These microbubbles are coming into the liver very fast, and they are having a special distribution into these tumors with washout. So first distribution, and then late, this is a washout, which is very typical for arterial venous shunts into the tumor, which are typical for neoplastic. So in this situation, with this patient, this is the complete diagnosis for a hepatocellular carcinoma. The next step is CT scan, and then we are going to make operation. This is a case I had many years ago with a young lady, 18 years old. She had, in very good situation of health, this nodule was detected by ultrasound in grayscale. In Doppler, I saw that there are some vessels inside. We did at that time, and it was the sending diagnosis of focal nodular hyperplasia, because in MRI she had this kind of image with the central scar, which is highly suspected to be a benign nodule. But in grayscale, and especially in contrast, there is enhancement in first, second of injection. Then there is washout. Washout means arterial, venous communication, which are malignant, highly specific. So with this image, we made the diagnosis of a malignant one. You have now here is the histology. It was a malignant nodule. So ultrasonography in these cases is very important to detect, to make a characterization, to follow, and to send the patient maybe to the upper, let's say, imaging procedures like CT scan, MRI, and finally surgery. When we talk about metastasis, this is a large imaging patterns. For instance, here we have many hyperechogenic metastases, multiple, some of them large, some of them small, after chemotherapy, partially effective. Not very effective, but anyway, this is a patient after 1 year of chemotherapy, and in some situations with patients who have this kind of disease, there is a modification of the pattern in grayscale of this situation. So this is the situation of we have a cancer of the colon, but here you can see another situation of a patient also with metastasis from cancer of the colon. He had this lesion which is not very clear. The liver is normal. The liver is not cirrhotic. The liver is normal. But in the segment 7, there is this flu delimited area of parenchyma. I put it the Doppler because Doppler is important. When you don't have contrast, you have to use Doppler in order to make characterization of malignant tumors. And I saw that there are some vessels around of the lesion, but not inside. It was a patient with chemotherapy. But with contrast, you see the big difference between the Doppler and contrast, because there is in second number 21, it's enhancement of the tumor before enhancement of the liver. And at 3 minutes and something more, you can see that the liver is still conserving, having contrast, but the tumor washed out because of arterial venous shunts, which are typical for malignancy. And you can see also on the right side the same situation of this patient, and this is the proof that it was in fact a metastasis. We don't have only malignant tumors into the liver, we have cysts. Cysts could be congenital, they could be developed in the life. What is important is that cysts are very easily to be detected because contrast between the consistency of the cyst and of the liver is very high. So we can see these cysts starting with, let's say, 3, 4, maybe 5 millimeters. And by comparison with anatomy, you can see these cysts could be many. What is the most important when you see this kind of cyst into the liver, look to the kidney, because the kidney is the organ who is going to be damaged in advanced situation of hepatic polycystic disease. We have sometimes parasitic cysts like this hydathic cyst, and you can see two kinds of. These are CT scan and ultrasound of the same patient, and you can make a comparison. The very typical aspect of a hydathic cyst is a well-defined lesion with sonolucent because of liquid part, because it's a liquid tumor, but some tumors like this one, they are becoming mothers for daughter cysts inside. So this is the very typical aspect of a hydathic cyst in the CT and especially in ultrasound, which is enough to make the diagnosis. Sometimes in this situation, when there is this double contour, double membrane, the name is called membrane detachment, and this is the situation of imminent of a very fast and the very next future complication of the hydathic cyst, because in this situation, because the cyst is becoming larger and larger, he's penetrating into the biliary tree, and then is going to penetrate. So it's a complication, it's an angiocholitic, which could be very, very severe. Liver abscesses, fluid areas with some area air inside. The most specific for liver abscess is contrast, but first, when we have the patient with septic status, we put the transducer. When we find some hypoechoic area with air, it's clear this is an abscess, and then we move to some benign tumors of the liver, and this is the very typical aspect of the hemangioma after contrast. Why do I say that? Because ultrasound is very good to detect lesions, including hemangiomas. But to make the specific diagnosis, you need contrast. Doppler is not enough. We know that hemangiomas are vascular tumors, but sometimes it could be misdiagnosis. For instance, here we have a very fatty liver. Many people are fat. They have hemangiomas inside because of the modification of penetration of ultrasound in the liver. In general, in standard situation, hemangioma is white, is hyper-echogenic, but in this situation is black. So I have the suspicion in this situation to be a malignant. I'm not very specific about the diagnosis of hemangioma, and that's why I do contrast, and I see that starting from the very first second of coming of that contrast into the liver until 4, 5, 6 minutes, we are going to see how the periphery of the tumor is becoming thicker and thicker because there is a penetration of the contrast from outside into inside until to the complete plenishment of the lesion. So this is the very typical of hemangioma. Also, we have focal nodular hypoplasia. Many young ladies, they have such a disease. This was a very, very interesting case, and that's why I'm going to present you. You can see on the right side what is the frequency of the focal nodular hypoplasia. Why do I present you this case? Because it was a lady, a Romanian lady, who lived in Italy, and she had severe disease, but only when she changed the position on the from staying on supine, she had no symptoms, but staying on the left side, she had acute pain of the right hypochondrium. Well, she was examined. The colleagues, they did the diagnosis of tumor of the liver, look and make a comparison between the tumor, which is a little bit black, and the liver, which is quite normal. In fact, it's a fatty liver. Finally, we examined the lady. We did also a comparison with MRI, but we did contrast, and the contrast showed that there is enhancement from the center to the periphery without washout in late phase, and this is a very typical ultrasound with contrast diagnosis for focal nodular hyperplasia. Finally, we had this confirmation by the MRI. The patient was operated. What was the explanation of the symptoms? She made a torsion of this exophytic focal nodular hyperplasia. It's an interesting case, and that's why I wanted to present it to you. This is a liver adenoma. It was not our diagnosis. It was a final diagnosis, but you can see that in liver adenoma, we detect on the left side the tumor in this case is very large, is very unhomogeneous. In contrast, there is an enhancement with some washout, but these washouts were necrosis. In liver adenoma, the diagnosis is quite difficult. I would like to say that ultrasonography is also very good for people who are working in emergencies. For instance, liver laceration is giving this destructuration, destroying of the structure of the liver. And then when we put the transducer, we see fluid around, we see fluid into the pleural space, we see the lesion, we put the Doppler, we see that vessels are maybe fractures, but what is the most important, contrast is giving the amplitude, the real dimension of the laceration of the liver. In spleen, also a lot of applications. These are indications for the spleen. You can see, for instance, infarcts into the spleen. Ultrasonography is detecting infarcts. These areas well defined, unhomogeneous nodules into the spleen, without very specific Doppler signs, but when we do contrast, we see that these areas are without vessels, and this is the compression. This is the CT scan. It was infarction of a spleen because of bacterial endocarditis. Another application for spleen, when we do embolization for hypersplenism, for instance, we are going to find this kind of spleen, which is becoming very complex with these bright spots inside. And when we look in contrast, this is liver and this is spleen, no vessels inside. So ultrasonography is good enough for making this diagnosis and to follow the efficiency of the procedure. In lymphoma, this kind of nodules, which are not typical for a specific case, but in multinodular lymphoma of the spleen, you might find this image. Lymphangioma, for instance, this is a lesion which is very similar to hydathic cyst, but is not hydathic cyst because we have vessels inside, and the confirmation by CT scan. I would like to underline all the time, please make comparison with CT scan, because ultrasonography is non-specific, is dependent on your experience, and if you are beginners, you have on your curve of accumulation of education, you have to compare to CT scan and MRI. So all the time, this is another case of a patient who was very, very severely ill. This is the spleen. Multiple lesions into the spleen, fluid into the pleural space, and this is metastasis of the pancreatic carcinoma and the confrontation with CT scan. Abscesses of the spleen are similar to what we see in the liver. This is a large abscess into the spleen. The spleen is unhomogeneous, but you can see that what is the difference between the beautiful image of CT and, let's say, the image of ultrasound. Ultrasound is focused on the lesion. CT is presenting not only the lesion, but also the whole atmosphere of the abdomen. So CT is more didactic, more didactic, more, of course, it's superior. But anyway, when you have the suspicion of the patient with abscess, he has pain in the left hypochondrium, upper abdominal. He has septic. I put the transducer. When I see this kind of image, I believe that it's obviously hypoechoic with air inside. I make the contrast. no vessels inside, it's a liver abscess. So combination with clinical details is very advantageous for us because we have the direct connection with the patient. This is another situation, very didactic in my opinion, because you can see it was a patient with a strong, it was a car accident finally. On the left side, you can see the spleen, unhomogeneous. I don't know exactly what is happening here, but I have the feeling because the patient had dropped of the hemoglobin and so on. I did a contrast. Now look what it is, the difference. The spleen is almost entirely damaged, and this is a large hematoma in this area. And this is a spectacular image, a patient with myeloma with a spontaneous rupture of spleen. It was an ultrasound diagnosis. The spleen is almost normal, but this is this line of fracture. There is some fluid around the spleen. What is the contribution of the contrast? First, we see it better. Second, we exclude other fractures. And then we exclude active high debit of hemorrhage, because it is also an important situation. So finally, I would like to say that ultrasonography, from the POCUS point of view, is a very good procedure to make the good diagnosis in many, I could say, majority cases of liver and disease, liver and spleen diseases. But combination with clinical data is important. This connection with the patient is important. We discuss with him. When we examine, we put the transducer, we compress, we look to the patient, he has pain and something. So it's important. We have this clue. We have the direct connection with the patient. The performance is related to the experience of the operator. So for young people, practice as much as possible daily, a lot of patients in order to achieve experience. Otherwise, you are going to be limited. It's a very good clinical instrument, but only if you have experience and practice, and this is what is important. And of course, remember, please, in case of uncertainty, ask the second opinion, and also make CT scan. Thank you very much for your attention.
Thank you very much, Professor Badia. A wonderful presentation of different kind of pathology in the liver and spleen. And because we are in delay now, I must invite Professor Esteemed. And I ask you, if you are thirsty and hungry, you can go one by one to the WOW secretary and to take with you and come back